sorry. There are some angles that help you to know that the reduction is correct or not. They are not too much, probably 10, 15, 20, something like that. But if you learn it, you are heading to know that the reduction is good or not. If the reduction is good, you are expecting that the range is going to be normal. If the reduction is not good, you're not ending of reduction. Yes? Yes? Reduction, part of the fragment, you want to keep it in the normal size, the normal situation. Normal, close to normal situation. Okay? It was happened by an orthopedic surgeon or physician, anyway. Okay, reduction. If the reduction was not correct, so probably your range cannot be reachable. Probably you have a limitation at the ending time of the range. Okay, so it's good to know that the reduction is good or not. So if you see the reduction is not complete, or there is a unnormal angle, okay, so you know that clearly you cannot reach ending range. So you consider it for your treatment. So probably close to the ending range, you're okay. Do you remember we do have anatomical range and functional range? Do you remember that? We are heading to reach functional range. It's better to get anatomical range, but if not, if you can't, it's okay. It's better to have at least functional range. You get my meaning? So we are trying to reach the functional range, and at the same time, if we can reach to anatomical range, it's okay. If we can't, at least we need a kind of functional. For instance, for the elbow, the anatomical is 0 to 145, 135, 140, something. But the functional range for the elbow is about 10, 15, 15, up to 100. You need something to use your hand, reach to mouth, okay? But better to have anatomical if you can, at least better to have functional. What about knee? What about knee? Anatomy is 0 to 1, again 45, 40. Okay. Functional is 0 up to at least 80. Why? You need it for gait. You need it for nourish, for cleaning, something like that. So you need much flexion. But for gait, you need 0. Here you don't need 0. For gait, you need 0. If you don't have the extension, full extension, what is happening? Remember gait. If you can't reach the full extension, you can't walk normally. You need full extension to put heel on the floor. Feet on the floor. It was a famous music. Feet on the floor. I do remember. Feet on the floor. Okay, so for functional range of the knee, you need full extension for it. And then, which range do you need? Then you need about, if you do remember gait, I don't think that you do remember. If you do remember the gait for the initial swing, mid swing, and full swing or complete swing, you are starting from about 30-degree extension up to the 60-degree or 70-degree flexion. So your functional range is something between 0 extension up to about 60, 40 flexion. So, in any case, it's better to have at least functional range. So your ambition, your goal is normal or actually anatomic range, but if you can't reach, at least have functional range. So all of these concepts refers to that one, that we do have some angles, and we must follow these angles to identify that can we reach the normal range, full range or not. And it helps you to see the reduction is normal or not. Probably it's not completely okay. This is a Bowman angle. There are different angles. I told you it's about 20, 25 angle at most. Okay, Bowman angle. What is the angle? You can identify the clarification. You know, I don't want to ask you to bring it on your mind. It's good if you can, but knows that there are some angles. You can refer to your notes to the slide to see if the reduction is good or not. But if you want to learn it, it's okay. I don't want to force you. It's a kind of concept, probably it's a little much complicated. So the Bowman angle is the angle between, have a look. What is this line? This line is the middle line, of, that one is radius, right? Wrong, it's ulna.
Ulna.
If I'm wrong, please correct me. Okay? Okay, it's ulna. It's the middle arm of the ulna. Okay, good. And when you have a middle arm of the ulna, and you have a line between the head of the humerus, head of the radius, this is the head of the radius. Okay, so the radius is located inside, right? Wrong. Radius is here. Pronation, supination, pronation, supination, supination. Okay. Between these two lines, you have about a degree of 75 degrees. If you had a fracture close to the end of the capital, if you have a fracture in this area, what is happening for the angle can be increased. Why? So in this way, that is the actually after the fracture healing, the picture is such as this picture. So you have a kind of limitation. You cannot reach to the full range of motion because the reduction does have a kind of problem, limitation. Did you get the concept? Good. So this is the Bowman angle. You can learn it, but it's not actually a force on there. Please consider or keep it on your notes or knowledge. Okay, so the lovely picture of the lower end of the humerus. And you talk about whole of the humerus today. Good job, good job. Okay, so at the end of the humerus, we do have two prominent area. Trochlea, capital. And which one is related to the joint of elbow? Trochlea. In Latin, they are all Latin, Greek. Yesterday we talked about the Greek. They are Greek. And in Greek, it means, I'm not sure, it means actually a roll which you can wrap some line on there, some wire on there, a roll. I'm not sure in Arabic, what is the meaning in Arabic? In Farsi we call it a line, rope for the switching some items, okay? You have a kind of circle, you have a kind of, how can I say, a place you can wrap all of the line on there. It's true claw. In Latin, it's true claw. For switching your, for instance, your button to your shirt. Okay.
بكرة
Buckle, I don't know.
بكرة مع الخياطة بكرة
خياطي.
ايه خياطة
خياطي. I'm not sure. خباز? No,
لا
خياط.
خياط
Okay. The line, what is the name in Arabic?
بكرة
Bakra.
ايه
Bakra. Maya said that. Bakra. True claw means bakra in Latin. Okay. What is the line here? This is the head of the ulna. This is the head of the ulna. This is radius, this is the ulna. Actually, the main bone for the elbow joint at the area of the forearm is ulna. Ulna and end of the humerus, which is trukla, bakla. Okay, so this is the only part of the article in forearm. You have the radius here, but there is no direct attachment between the head of the radius and capital lobe. It's just a kind of functional movement, just for the pronation, supination. Okay, but the joint is including trukla and also the ulnar head, the crocoid process. What was the name? What was the meaning of crocoid? Beak. Crocoid process, and part of the head of the arm. Okay. So, what was the type of this elbow, this joint? What was the type of that? What was the type of that?
Hinge.
Hinge. Great. Don't think about that. As far as I'm asking, you must say hinge. Hinge. And what is the problem with hip joint? So limited. If they has a kind of problem like a door, so it was not closed. It will not be closed. It will not be opened. Just very simple does have a problem. Okay? Everything is fine. Everything is fine. Okay, so how many hinge joint does we have?
Two.
How many hinge joint? You are thinking. How many hinge joint?
Two.
Pure hinge. Just fingers, IP, PIP, and just elbow. So it's not very important because you cannot work with them so much. But it's very important. All of the function relate to your mouth, to your head, to your washing, nourishing, or using for instance, dressing, something like that. You need the elbow. You need the elbow. And if you have a problem on the range of motion, what is happening? You can't. How I close my button? Is it possible? You want to force it? If you want to force it, what is happening? HO. Anybody do remember HO? What is the meaning of HO? Noor is tired. HO, heterotropic ossification. Heterotropic ossification. That means extra ossification, you don't need it. So, HO, heterotropic ossification. And if you have HO, what is happening? You can't close or open in an appropriate range. So, how can you reach HO? So that you have a problem here in a hinge joint, not all of the joint. In a hinge joint, and you want to forcefully make it full range. It creates increased amount of the HO. So as far as your increased force, the range gonna be much limited. If you increase force, hold, relax. See the patient, for instance, in burn disorder. Okay, I can do that. Hold, relax, contract, relax. So, then the day after that, a patient come to your office and see that the range is much limited compared to yesterday. Repeat it a week, 2 weeks, 3 weeks. It can't actually even move it. There are lots of edge odor. Okay, don't force any kind of hinge joint. Don't provide force any kind of hinge joint. Okay? Okay? Okay, okay? You are talking with each other. How you say okay? Don't force on any kind of hinge joint. Okay. Okay, so have a look, ladies, to these type of the fractures at lower end of the humerus. It's just have a look. It's a kind of classification, and as you can see, there are different types based on two concepts. You know that A, B, C. This is a general concept. You know that. It's type of classification. Doesn't matter. Probably a physician like to classify this type of fracture in 4 groups, 5 groups, 6 groups. You know the whole concept, the stability, amount of the stability. You are following the concept, not actually exactly the number or type of classification, something like that. So the whole concept is after the fracture, you must follow stability. Okay, how can you reach a stability? Good reduction, stay for a while to reach third cortical bridging. To reach third cortical bridging. How long? 18 to 21 days. Okay, so how can you reach good reduction? Okay, clear. You must provide a kind of anatomical or close to anatomical shape, reach together, and then reach part of the bone, part of the fragments, and you must keep it as soon as closer. I'm talking about the segments, okay. If there is a distance, it's gonna be worse for healing. So, we did have a key 1 centimeter at most. More than 1 centimeter gonna be a kind of delayed union. So for good reduction, you must keep it, for instance, close to each other, lower than 1 centimeter. There is another sign, angulation. 45 degree or more than that gonna be worse. So good to reach to lower than 45 degree and close to the anatomical position. Okay, we are based on the classification, which is very actually famous.
Doctor, type 2 symbol more for type 1?
Type 2 is what?
Symbol?
No,
Type
actually
1 is
simple, much simple, you mean?
Yes.
No, because in type 1, you have just detach about 1 centimeter. It's completely rotates, so it cannot be attached.
Yes.
Okay, angulation, more than 45 degree. Here is, what is that? Is it capitulum or coracoid? Is it trochlea or coracoid?
No,
Which
okay.
one? It's capitulum, none of them. Capitulum, trochlea. Coracoid is on the ulna. Okay, so it's multi-fragment. It's worse to work. Multi-fragment, and you can see trochlea. Which one is worse to work? Have a look, ladies. You check the X-ray to see what should I do with this patient. Okay, among these two, which one is harder to work? Which one is harder to work?
What?
The question is, among these two, which one is harder to work? Let me see. Which one is harder to work?
Type 2.
Good.
Because
Which one is harder to work? Type?
Type 4
Why?
يعني
You are correct, but why?
يعني صار هيك مبسوط.
I think rotation.
No, there is no rotation. Very easy, easy. It's part of the elbow joint. This is not elbow joint. So it's very hard to cover it. You know, it's tricula, gonna be linked with ulna. It's part of elbow joint. Good job. Okay. You have seen lateral epicondylitis, medial epicondylitis. Lateral epicondylitis is actually very famous problem. Do you remember? Tennis elbow, lateral epicondylitis, or medial epicondylitis. You haven't heard tennis elbow?
Yes.
Golfer elbow. That refers to the connective tissue. You will learn it next semester, not now. But you have like anyhow. In any case, you have a problem. Have a look. That one is the fracture for the lateral epicondylitis here, for lateral epicondylitis. This is a kind of complex capitulum and trochlea, capitulum and mid-trochlea. Which one is harder?
Big part of the joint.
Because it's part of the joint.
Yes.
And what about that one? Which one is harder?
C.
Why?
Because the rotation, complete rotation.
Angulation. Good job.
يعني
Good job. Why is not working? Come on. Okay. Have a look to the pictures. Very nice actually X-ray. This is, I think, lateral epicondyle, right?
Yes.
No, wrong.
Lateral.
This is medial epicondyle.
medium.
That one is lateral epicondyle. How can I understand it? How can I find it? With lion and line.
هذا ميديوم الأول.
How can I
اليوم
find it?
الأولنا هذا.
What?
أول حاجة الأولنا هذا.
What is it with this small?
This
Not
arm.
physio.
راديال.
You must say everything with closed eyes. With closed eyes.
Humeral and regional ulna.
When you have a radius, head of the radius here. This is the lateral area. So
This
this is
radius
lateral,
and-
this is medial. Okay? It's the ulna, it's the radius. And you see the radius here. So, this is posterior aspect or anterior aspect? You are physio with closed eyes. Not really with closed.
posterior.
Why?
Because
تراكيا. فوسا of ايش اسمه هذا؟ humerus.
Somehow you're so professional because of that one. I found it because of that one. It's superimposed. It shows actually two bones to each other. The density is higher. So it shows actually you see the back of the ulna and also humerus as well. In front you haven't seen this one. There is no superimposed. Did you get my meaning? Okay. Good. I think we can continue tomorrow morning as well.
no.
You are planning for vacation. Ready. Ready. After 12, you are a sergeant. Okay. nice actually lateral epicondylitis, you see the surgeon provides some kind of simple, what was the name of these items? Intermedullary nail. Intermedullary nail, plate, a screw. Come on, what was the name of that one? Wire, simple wire, car wire. Okay, so provide a kind of stability with the wire, and please tell me everything is fine. Fine. This is a fractures area, and they put the epicondyle close to the area of the bone and use the wire to keep it at the area. So you know the wire is out of the body. Okay, you see. The most important problem here is risk of infection. Risk of infection.
Out the body?
Risk of infection. And you guess how long we keep it? What is your guess? Lion. How long we keep it?
When the
At least
شنو هو سؤالك؟
3 weeks?
at least 3 weeks. But you know, because this is a huge bone, I mean, this is a big bone, not very small. We're not talking about the fingers. Because this is a big bone, and because of some probably other disorders around the joint, probably, so it takes time, probably 4, 5, 6 weeks instead of 3. But if you will be in an area like finger, so it's 3 is fine, you know. So, and after 3, the surgeon must remove it. And how long we keep it? We keep the devices. We can keep it up to 1.5 years. Not this device. This is the risk of infection. You can remove it, okay? So when you have this picture, the patient come to you at the month 2nd, at the end of 8 weeks. Okay, you can't see any wire. You see just normal actually shape. Okay, so but ask the patient. Okay, please bring me the X-ray. Check the X-ray. What is happening? Check the X-ray. Okay, that was your surgery. Okay, when you remove it, you said that. Okay, 2 weeks ago, 3 weeks ago, after 2 months. Okay, so what is your estimation? You know the meaning of estimation? What do you think will be happen? Estimation? Hura, estimation, what is
لا هذا
estimation? You are not confident that you reach it, but actually you may reach it or not. Estimation. In Farsi we call it تخمين.
تخمين yes تخمين
تخمين. Okay. What is your estimation for this patient? This is a hinge joint with a kind of immobilized.
Limitation of movement.
Perfect. Hinge joint with a kind of immobilization for 5 weeks, 6 weeks, and he removes it. You may have a kind of, you may not reach to full range. You may not reach to full range. Okay, so it's completely clear. If you are not reaching to full range, you are not able to force it. HO is here, is ready to create worse situation. Okay. Okay, everything is set. What about medial epicondyle? Have a look, medial epicondyle. You can check it easily through checking the radius and ulna. When it's here, so it's medial. It's partially go enter to true claw. It's partially go into the joint. Everything is set. I knows that, and so it's going to be a little harder to work. And so, have a look, radius. So it's medial. Okay. And so, feeling